Good day. I am Colonel Frederick Lau, Director of the Department of Defense Medical Ethics Center at the Uniformed Services University of the Health Sciences in Bethesda, Maryland. Today, our military treatment facilities are reopening while still dealing with the many issues involving the COVID-19 pandemic. Non-emergent but medically necessary procedures and operations are being conducted in this environment. Informed consent is a critical element in the safe and proper conduct of surgery and medicine. This presentation will address this issue and provide our recommendation to include a discussion of the potential risk, though small, of acquiring COVID-19 during and after the perioperative period. Welcome to the Department of Defense Medical Ethics Center's presentation of the ethical, legal, and clinical issues clinicians should consider when establishing patient-informed consent in the era of COVID-19. Informed consent is defined as permission granted in the knowledge of the possible consequences and given by a patient to a doctor for treatment with full knowledge of the possible risks and benefits. Informed consent is fundamental in both ethics and law to medical treatment. The principles of autonomy, beneficence, and justice are basic to these ethical issues and merit your consideration. Today, the Department of Defense military health system faces the challenge of opening its facilities to patients for treatment, to include surgery, while at the same time dealing with COVID-19 pandemic. The following presentation will advocate that a discussion of COVID-19 be included in the informed consent process and that the specific discussion of COVID-19 be well documented in the patient chart.
Today, our presenters will be the following: Colonel Frederick Lau, Director, DMEC; Mr. Joseph Povich, Legal Advisor, DMEC; Professor James Giordano, Bioethicist, DMEC; Dr. Megan Applewhite, Bioethicist, DMEC; myself, Alexani Combs, Program and Management Analyst; and Mr. Joshua Curtin, Deputy Director, DMEC. The following slides contain the biographies of our presenters. None of the presenters today have any financial relationship to the content of this presentation. The views expressed are solely those of the presenters. No commercial support was received for this presentation. Colonel Lau will now show us the learning objectives for today's program.
The learning objectives include: 1, recognize the critical and elevated importance of the informed consent process in the COVID-19 clinical environment. 2, understand the ethical principles relevant to the informed consent process in the COVID-19 clinical environment. 3, understand the legal significance of the informed consent process in the COVID-19 clinical environment. 4, review some clinical techniques that military treatment facilities and healthcare professionals can use to broach the informed consent process with their patients in the COVID-19 clinical environment. The following guidance is provided by experts in the areas of medicine, bioethics, and law. The comments of the panel should not be construed as official policy of the Department of Defense Health Affairs or the Defense Health Agency. The bioethics guidance is non-prescriptive and meant to aid Department of Defense healthcare professionals dealing with the complex ethical challenges. The COVID-19 pandemic is a dynamic situation and will require flexibility and responsiveness. To quote Benjamin Franklin, "By failing to prepare, you are preparing to fail." The issues included are designed to address some challenges before they are encountered in real time in the military treatment facilities.
Thank you, Colonel Lau. Mr. Curtin will now bring us up to date on the current DMEC activities.
Thank you very much, Ms. Combs. Good day. I'm Josh Curtin, the Deputy Director of the DMEC, and the comments for my presentation are contained on slide 14. First off, thanks kindly to everyone for watching our video presentation. Thanks also to all of my impressive DMEC colleagues for both their time and expertise. My objective is simply to review some of the guidance that the DMEC has already provided in previous installments. First, the DMEC produced and disseminated throughout the MHS our bioethics guidance on the COVID-19 pandemic, which contains various ethical considerations and numerous pragmatic recommendations. In sequence, the DMEC also created a companion video which addressed the guidance contained in our inaugural document, as well as the inclusion of a general Q&A session focusing on the most pressing ethical concerns we heard from MTF healthcare professionals in the field. Both of those materials are available on the DMEC website and will be as relevant during a potential resurgent wave in the summer and fall season as they were during the initial onslaught of this pandemic. The DMEC has also created a follow-up document which provides bioethics guidance for consideration as the MHS begins to reopen from the more restrictive quarantine measures imposed throughout both the country and the globe. That document highlights various ethical principles for consideration as MTF healthcare professionals face the ensuing wave of clinical challenges in this evolving COVID-19 pandemic. Our objective in doing so was to identify the next set of ethical issues that will be encountered within the MTS and provide some non-prescriptive guidance in turn for thought consideration in preparation. Again, that document will also be available on the DMEC website, the URL for which is provided on the last slide of this presentation. Finally, our topic of discussion for today is focused on the informed consent process and how that fundamental medical practice will be influenced by the unique COVID-19 environment within the legal, ethical, and clinical domains. That concludes all of my remarks. Thanks kindly for your time and attention. Please feel free to reach out to the DMEC directly if we can assist in any way possible going forward. I will now turn the presentation back over to Ms. Combs.
Thank you, Mr. Curtin. Mr. Procaccino will now discuss the ethical, legal implications in the informed consent process.
Thank you, Ms. Combs. I'm privileged to be co-presenting with my esteemed colleagues for this topical and critical subject today. I'm reminded when I think of the area of informed consent of an old Italian proverb, dagli avvocati e medici mi salvi Dio, which translates, God help me from doctors and lawyers. And one of the issues that quite often provokes that kind of commentary is the confusion in getting information to be able to make an informed consent on something that is critical to one's life and health. I'm going to expand a little bit on the definition that Dr. Lau used earlier in saying that informed consent is essentially that consent obtained, as you can see on the slide, after the patient has been given, and notice the words in red here because they're significant, sufficient information, whatever that word means, so that he or she understands substantially, whatever that may mean, the nature of the procedure to be performed. In other words, what am I going to do to your body? The risks and consequences associated with it. What could go wrong with what I'm going to do to your body? What are the benefits to be expected? What do we hope to obtain or attain by doing this to your body? And are there any other therapies or treatments that could be available? And why am I doing this one as opposed to another? It's also important to realize that the patient has always the right to ask questions and, yes, the right to refuse. When we go back and we look at those words in red, it provokes a number of commentaries. First of all, it's very important in discussing a situation with a patient to use language that the patient truly can understand. People in the medical profession are generally very educated individuals and tend, because of the vocabulary that's involved in medical terminology, to use polysyllabic vocabulary, which the general population may not really truly understand. So as an example, if a doctor comes in to visit a patient and says, "Madam, you're going to have a salpingo-oophorectomy. Do you have any questions?" It'd be nice to be able to break that down and discuss in real terms what that actually means. If we don't do that, we run the risk later on of having a patient coming into court and saying, "I didn't really understand what the doctor was saying, but was too afraid to challenge him or her under the circumstances." In addition to that, documentation becomes very, very important to be able to at least demonstrate that information was indeed given to the patient and that a consent was elicited from the patient. The problem with documentation, though, is how much do you put down, because you can end up writing a tome sometimes about a particular procedure or therapy that's going to be offered. So it has to be something that's within the element of reason, and we'll see that word pop up again in a second. It's also very, very important to discuss, if there are alternative therapies, what those are and why you are indeed doing this particular type of procedure. In this area of coronavirus, we've heard so much in the media about different methods of care for various people that inevitably you're going to get questions from patients as to, why are you doing this to me or my loved one as opposed to something else I heard about? And you need to be able to discuss that when that issue is raised. As you can see on the slide, one of the critical things for healthcare providers is a risk analysis. And what I mean by this, balancing, if you will, the seriousness of the risk versus the frequency of the risk, and deciding what is really necessary to discuss with the patient. Because indeed, one could go to a water fountain in the hospital and drown, and yet are we going to go ahead and tell them that as a potential risk of something that could happen like that? It has to be something that is of a certain degree of seriousness or a certain degree of frequency that would elevate it to the point that requires discussion. And that's something that the provider is going to have to look at with his or her colleagues, as well as analyzing the individual patient to see what is important to the patient and why that needs to be discussed with them. Going down a little bit regarding the issue of risk, we might quite often find that a patient may not necessarily have the capacity or indeed the competency to be able to offer a consent, particularly in a COVID environment. In that situation, you may look to the next legal representative to be able to elicit an informed consent. And here we run into a number of potential difficulties. You'll see a term used on the slide here, the Ulysses Consent. It's an ethical principle that goes back to Greek mythology with the captain of the ship Ulysses, and inevitably the discussion here regards whether or not one has a right to change one's mind, and if one does change one's mind after initially consenting to a treatment or procedure, is that an indication that the person is not competent, or perhaps were they competent initially or not competent initially when the consent was first given? And that can also become a dilemma for a provider with a patient, or even more awkwardly, a patient's family member changing their mind about what they want or do not want to be done. I would also note that when we're dealing with off-label medications and clinical studies, which we're hearing a lot about in the COVID world here, that for off-label medications, it's interesting that case law tells us that it is not necessary for a provider to tell a patient that the medication being recommended is off-label, because it has been presumably FDA approved in and of itself, albeit not for this particular use. However, if we're dealing with any patients involved in clinical studies, it is highly recommended that the providers refer to 45 Code of Federal Regulations, section 46.116. And this is the section in the Code of Federal Regulations that speaks to informed consent in clinical studies. And you will find that the requirements for informed consent are much more robust than even in normal informed consent situations. States have been divided between physician discretion and full disclosure. In other words, there are some jurisdictions that may allow the doctor essentially to tell the patient what the doctor believes is important for the patient to know. However, there has been a trend, and the majority of jurisdictions now follow a full disclosure standard, where essentially the patient has the right to know all the goods, bads, and uglies that may come with a particular procedure. In a COVID world, this becomes more difficult because some of the discussion may get very, very awkward, including the question of the use of ventilators, ECMO, other things, again, people are reading about inside the media or just talking among themselves. Inevitably, however, for the provider, we're talking about a reasonable person standard. When one goes into a courtroom, one would presume if a doctor is being accused of not offering sufficient information to get an informed consent, that the information that was given is something that would be understood by a reasonable person. The question becomes then, how do you define that? And it's not something that can easily be done in black and white. Another issue that comes in is the issue of beneficence and provider motivation. I'm reminded of an analogous issue of a case that occurred in one of our MTFs a number of years ago of a patient that was in a terrible car wreck and had a broken neck. The doctor in the hospital recommended the implantation of a stainless steel halo around her skull and neck to be able to stabilize the neck. He explained all of this to her. She consented to the procedure, and it indeed was implanted, including screws into her skull. A few days later, she came back to the hospital screaming, demanding that the halo be removed. The doctor refused to do it, saying that if he did, it would result in her death. And she came back and said, "This is my body. I autonomously have the right to say and not say what is done with my body, and I demand you take it off." The doctor, acting beneficently and non-maleficently, responds saying, "I cannot do that because I cannot allow you to die, and it violates my ethical standards." Who's right in that situation? And this is what gets us in to the ethical aspects of this. I leave my slide with the bottom section talking about the concept of therapeutic privilege. This is something that is very awkward in the medical community because it does give the physician some discretion on how one relates the truth to a patient. Obviously, there are certain patients that, due to anxiety or due to other physical or mental conditions, if you tell someone straight off exactly what the ramifications may be of treatment or non-treatment, it may actually exacerbate the problems that they have. So the trick then is, how does one massage that truth while not lying to be able to get the information across without causing that exacerbation? Therapeutic privilege really is a great springboard into a more erudite ethical discussion. And I will then pass that along to the ethical experts that are also along with this video. Thank you.
Thank you, Mr. Povich Inno. Professor Giordano will present the ethical principles involved in the informed consent process.
Thank you, Ms. Combs, and thank you, Mr. Povich Inno, for the excellent discussion of the legal basis that in many ways work interactively and dynamic with those ethical precepts upon which the clinical encounter is based. You've raised a good point with regard to what the physician and philosopher Edmund Pellegrino refers to as the clinician's discretionary space. And part of that discretionary space is hinged upon and contingent upon knowing the patient. What can this patient at this time handle as regards to the extent of truth relative to their decision-making for the province of their own care? And this reflects greatly the idea of therapeutic privilege as a fundamental construct of clinical interaction. Therapeutic privilege is indeed a reciprocating privilege. On the part of the clinician, it is the privilege to engage in the intimacy of that clinical encounter, a literal intimacy. But it is in fact twofold. On the part of the patient, it is those privileges that are bequeathed to the clinician by that patient for that clinician to uphold their autonomy in and for that patient's best interests. Which then brings us back to the construct of autonomy as being fundamental, at least in an open society, for the conduct of clinical care. Certainly, there are a number of philosophical dimensions that go into the idea of autonomy, and they range from those things that are deeply deontological and based upon individual duties to those that are far more applied and interface directly between ethics and law. But perhaps at its most basic, autonomy is here regarded as affording the negative right of refusal, as Mr. Procaccino so well illustrated in his erudite presentation of the case of the individual who received a cervical fracture, a broken neck, and then decided, no, I don't want you to put this cervical halo on me for whatever reason. There's that thin line between the perceived beneficence of the clinician and what the patient may view as intrusive, harmful, unduly burdensome, or risky. Realistically, it becomes the clinician's obligation to explain those benefits, burdens, and risks, and this is entailed by the principle and or virtue of veracity, truth-telling in medicine. But once again, Mr. Procaccino's discussion, such veracity may have discrete limits, which can in fact be metered by the clinician in an understanding of what this patient can handle at this time, given the probity of that information to determine their best interests. But there are also things that the clinician may not know. This is the virtue, if you will, of intellectual honesty. The physician communicating the limits of what they know and what can be done. And in times such as these, in the COVID crisis, there are indeed defined limits that are contingent upon what techniques and technology science affords us to gain insight both to the disease and to its manifestations in unique patients under discrete and differential circumstances. But what guides whatever it is we do, based upon however much we know, is benevolence, wanting to do good. And the exercise of benevolence, upon which autonomy is based, is beneficence in trust. That is, that the clinician will act in the primacy of patients' best interest, inclusive of informing each and all patients for consideration of not only their individual good, but how their care and or the limits of their care may be necessitated and dictated by an appreciation for and articulation of the collective good. And let's face it, ladies and gentlemen, this is primary to our considerations of military medicine. For in military medicine, what we seek to do is treat the force one patient at a time. And in times of crisis, as you've heard from our previous presentations, the overall consideration is to maximize the benefit to both one and all, and to maximize the benefit to all by maximizing what we do to those individuals with whom we treat. Making sure those individuals are fully appraised and understand the contingencies that arise from treating individuals as part of a collective is fundamental to exercising their autonomy and to exercising the clinician's capability of informing patients so as to gain their consent. Irrespective of the extent of good that can indeed be articulated, what we seek to do is not harm. Right out of the Hippocratic corpus. Seek always to do good, but when such goods cannot be articulated in full, at least do not harm. At least do not harm. Which essentially also means what harms will we try to avoid, not only now, but in the future. And this becomes particularly important when the nature of those treatments that we offer to patients are new or are novel examples and articulations of those things that we may have used in different ways, utilizing drugs or devices off-label to be able to deal with the exigencies of this crisis situation. And this then brings us to the ultimate contingencies upon which consent is structured. If indeed we're taking patients farther than we have gone before, using tools and techniques that have not been used in these ways to this extent before, and we're informing our patients of that, perhaps what becomes necessary both idiosyncratically, in other words, on the individual level, as well as systemically, is to provide them with information about the availability or non-availability of continuity of research to assess if and when things might go wrong via the treatments we have offered, and continuity of clinical care to provide a relative safety net for these patients who then receive such care, so that should things go wrong in the future, the medical system will indeed take care of them. Please understand, ladies and gentlemen, that these contingencies are not always available. And in that lack of availability, it becomes important to inform patients of those paucities of research and care so that they can then make decisions about whether or not they will bravely go where others have not gone before, and do so in a way that reflects their best interests as well as the reciprocating best interests of the collective and the goals and beneficent acts of the clinician. Thank you. Ms. Combs, over to you.
Thank you, Professor Giordano. The next two slides dealing with the clinical techniques of reviewing informed consent with patients will be discussed by Dr. Applewhite.
Thank you, Polly. I'm grateful for the opportunity to collaborate on this important topic with my esteemed colleagues in DMEC and talk to you all today about some clinical techniques that we can keep in mind while reviewing informed consent with patients during the COVID-19 pandemic. A basic assumption about informed consent is that the physician performing the intervention is intimately familiar with the risks involved, such that he or she is able to outline them in a straightforward way that allows the patient to weigh those risks with the anticipated benefits and compare any alternatives. When thinking about surgery in the COVID-19 pandemic, informed consent becomes more complicated because the basic assumption is challenged. Certainly, the risks as they pertain to the technical aspects of the intervention are the same, but there are new risks that arise in this pandemic that the surgeon is almost certainly less knowledgeable about, yet is ethically responsible to discuss. For example, the risk of an uninfected patient acquiring COVID-19 in the perioperative period is unknown. Certainly, a patient could be exposed en route to preoperative appointments, during their hospital stay at the time of surgery, or even at a stop on the way home following recovery. Regardless, the risk of acquiring COVID-19 is almost certainly higher than if they stayed at home and out of the hospital entirely. Secondly, although data are still being gathered, the true risk of anesthesia and surgery itself to patients who are either asymptomatic and infected with COVID-19 or who contract COVID-19 while recovering are unknown. Finally, depending on the type of medical facility, access to critical care resources may be more limited than in times outside a pandemic, and this is important to communicate. Given the uncertainty of how the COVID-19 pandemic could affect patients undergoing interventions, some guidance regarding informed consent would be to, as always, remain as honest as you can with the patient. In a straightforward way, recognize that despite the best efforts of the medical facility, the patient may contract COVID-19 in the perioperative period. Recognize that the institution will attempt to mitigate this risk by taking appropriate precautions, including donning personal protective equipment, engaging in physical distancing when possible, and minimizing visitors to decrease the risk of exposure. Additionally, it is recommended that physicians tailor their discussion to each patient's individual predisposing risk factors that may make them more vulnerable, such as pre-existing lung disease and immunocompromised status, in order to determine if the benefits of a successful intervention outweigh those risks. We recommend, when possible, to elicit goals and preferences for life-sustaining treatment if the patient should have unanticipated intraoperative or postoperative complications. Finally, it is of critical importance that documenting the details of informed consent in the patient chart occurs. I'd now like to invite Colonel Lau to make any additional comments.
Dr. Applewhite, thank you very much for your contribution. I'd like to add my comments and to review. The informed consent process and the attendant documents are the most important documents in the patient chart. The operation permit has both the patient's signature and the physician's signature and establishes the interrelationship of the patient and the surgeon. The significant elements of the informed consent are the specific diagnosis, the various options for treatment, the surgeon's recommended treatment, the proposed patient course before, during, and after surgery, and the potential risks assumed by both the patient and the surgeon if the patient elects to proceed with surgery. The era of COVID-19 has raised the specter of additional and unknown risks, as my colleagues have presented. These risks include issues before, during, and after the proposed surgical event. Therefore, it is extremely important that the risk of COVID-19 be addressed in a forthright and direct manner. If possible, it is also highly recommended that an independent party be present for this counseling session. Additionally, most surgical procedures are elective in nature, but in some situations, time is limited, such as a traumatic injury. When time is limited, the surgeons need to do what they can to establish some form of informed consent, with the added recognition that the reasonable patient would elect to have the proposed life-saving procedure. The above comments also apply to the anesthesia team as well. And because trauma patients are typically treated by a team of surgeons, the issue of COVID-19 should be included in this discussion. Documentation of all the elements of this conversation is critical. Remember, if it is not in the chart, it did not happen. The COVID-19 pandemic will pass, but the medical legal issues are only now beginning to come to the fore. Attention to the matter of the informed consent in the COVID-19 pandemic is of paramount importance to military and contract physicians, to the military treatment facilities, and to the Department of Defense. Finally, our key takeaways are, as the military health system begins to reopen from quarantine measures, there will be new and dynamic ethical challenges to confront and resolve within the military treatment facilities. The informed consent process for patients who will be undergoing medically necessary procedures is an issue that requires significant consideration and evaluation to be addressed by the military treatment facilities' healthcare professionals. Collateral coordination will be required with other military treatment facility professionals to provide the best possible advice, such as legal, patient relations, and quality assurance. Thank you very much, and I'll now return the presentation to Ms. Combs.
Thank you, Colonel Lau. References for this presentation are cited here. Any questions or comments can be directed to our DMEC team listed here. All the material discussed today will be available on the DMEC website, which is on this final slide. Thank you for your attention and have a great day.
Thank you for your attention. My colleagues and I stand ready to assist you with the many ethical issues you may encounter as you provide care to our warriors and their families.